Thank you. Good evening, everyone. I'm Dr. Farha Maloo, and today I'll be excited to present an intriguing topic, oral manifestations of systemic diseases. Drawing from my extensive experience in ENT and head and neck surgery, I have encountered numerous cases where oral manifestations serve as crucial indicators for diagnosing various systemic conditions. Let's delve into this fascinating intersection between oral health and systemic well-being. The oral cavity reflects the overall status of the body, including hydration and various other systemic organs. The presentations in the oral cavity could be initial signs of various acute or chronic systemic conditions. Vice versa, pathology processes that occur in the teeth, the tongue, the jaws, and all the contiguous structures like the mucosa could have a very significant impact on one's overall systemic condition. Therefore, an early diagnosis is very important in order to identify these subtle changes in the oral cavity. So the agenda for today's presentation would be the following. We will deal with gastrointestinal diseases, endocrine disorders, autoimmune diseases, granulomatous conditions, nutritional deficiencies. Then we will move on to the infections by various bacteria, viruses, and fungi. Towards the end, we will have a look at how the pre-malignant and malignant diseases present in the oral cavity. Let's start with the first most important gastrointestinal disease, which is GERD. GERD, or the gastroesophageal reflux disease, results because of the reflux of acidic contents from the stomach into the oral cavity and the oropharynx. This causes a reduction in the pH and subsequent destruction of the enamel. Destruction of enamel would predispose the patient to recurrent dental caries and bad breath or halitosis. As evident from the picture, there is acid erosion on the occlusal surfaces of the mandibular teeth in the patient with GERD. The next disease is the Crohn's disease. Crohn's disease is an inflammatory bowel disorder which occurs specifically in all the layers of the bowel walls. There is inflammation of all the layers of the bowel walls. It presents in the oral cavity with diffuse mucosal swelling and something called as pyostomatitis. Pyostomatitis is basically pus and inflammation of the occlusal surfaces of the buccal mucosa. There is a classic presentation in the Crohn's disease, which is known as cobblestoning and snail track ulcers. These ulcers are yellowish with serpentine pustules and erythematous base. The next inflammatory bowel disease I would like to discuss is the ulcerative colitis. So, unlike the Crohn's disease, ulcerative colitis occurs only in the superficial most layer of the bowel wall. It will present with aphthous ulcers in the labial mucosa as well as the buccal mucosa. There will be progressive necrosis along with deep ulcerations on the tongue. Now we will look at patients who have got chronic liver diseases. In these patients, when the bilirubin levels increase to 2 or 3 times that of the normal levels, there will be yellow discoloration of the mucosal surfaces, especially in the sublingual region and the soft palate. Chronic liver diseases will result in prolonged thrombocytopenia or decreased platelet counts. This will cause petechia formation in the mucosa of the oral cavity as evident from this picture. Now we'll look at how hepatitis C presents in the oral cavity. Hepatitis C is a viral-induced hepatitis which produces white lacy patches along with red swollen tissues and open sores in the oral cavity. These lacy patches, they mimic a condition known as oral lichen planus, which we will be dealing in depth later on in the presentation. This oral lichen planus type of formation occurs mainly because of the cell-mediated cytotoxicity or the HCV virus-induced increased cytokine hyperactivity. These are the classic white lacy lines and oral lichen planus type condition which hepatitis C presents. Now let us look at how the various bleeding disorders present. Bleeding disorders like hemophilia and von Willebrand disease, along with platelet disorders like thrombotic thrombocytopenic purpura, which is the inherited form of the disease, or idiopathic thrombocytopenic purpura, which is the acquired form of the disease, will present as petechia formation on the mucosal surfaces, purpura in the soft palate, as well as recurrent bleeding of the gums. Moving on to the Behçet's disease. Behçet's disease is an autoinflammatory systemic vasculitis of unknown etiology. It is characterized by mucocutaneous manifestations along with recurrent oral and genital ulcers and the classic ocular manifestations of chronic relapsing uveitis. In the oral cavity, Behçet's disease will present as recurrent painful aphthous ulcers, which are typically seen in the oropharynx and the soft palate. The Kawasaki disease presents as erythema of the hands and the feet along with fever and rash. Kawasaki disease occurs because of inflammation in the walls of the small and the medium-sized blood vessels. It results in ulcers in the oral cavity, and there is typical swelling of the tongue papillae, which gives characteristic strawberry appearance of the tongue. And also the patient will have cracked, swollen, cherry red colored lips. Now we will be dealing with metabolic disorders or endocrine disorders. The first one is the Addison's disease. Addison's disease is characterized by decreased cortisol levels. These decreased cortisol levels will in turn cause increased ACTH production. ACTH will stimulate the melanocortin receptors and increase melanin production. This produces the characteristic mucosal hyperpigmentation and flat brownish plaques on the mucosa of the lips as well as the buccal cavity. Now, the Cushing syndrome is because of the increased cortisol levels. This results in the moon-shaped faces and the chubby cheeks. Cushing syndrome will present as prominent bilateral indentation marks on the buccal mucosa and severe ulceration of the teeth. Diabetes mellitus is the most common endocrine disorder. Diabetes is known to cause several neuropathies as well as microvascular abnormalities. These abnormalities, if they affect the salivary glands, will result in decreased salivary production. This will cause dry, cracked lips, as well as periodontal diseases or diseases of the gums. Diabetes mellitus will predispose the patient to hypoimmunity and result in fungal infections by Candida albicans. This is the picture of Candida affected tongue. Diabetes mellitus patients will have poor wound healing. So any ulcerations in the mouth will take a very long time to heal. Congenital hypothyroidism. Children born with congenital hypothyroidism could have thyroid dysharmonogenesis or complete thyroid agenesis. These children will present with abnormally enlarged tongue or macroglossia and delayed tooth eruption. Acromegaly or gigantism is because of increased growth hormone. This causes protruding mandible or prognathia. This will result in dental malocclusion and thickened lips. Hyperparathyroidism. Now, Increased in parathyroid hormones will result in mineral disturbances like increased vitamin D levels, calcium levels, decreased phosphate levels, along with resultant renal failure. This causes bony resorption, which results in jaw bone cortex thinning. Because of the thinning of this cortex, there will be loosening of the teeth, evident on this X-ray. Now we will look at some granulomatous diseases in detail. Sjogren syndrome. Sjogren syndrome is a chronic autoimmune disorder that happens generally affecting the salivary glands and the lacrimal glands. The decreased salivary volume will decrease the ability of the saliva to dilute the dietary sugars. Increased dietary sugars in the oral cavity will in turn cause proliferation of the bacteria causing caries. So the patients will present with increased dental caries, cracked lips, and deeply fissured tongue. This you can see the deeply fissured tongue in the picture and the dental caries. Another chronic granulomatous disease is the scleroderma. Scleroderma is a component of the CREST syndrome, where C stands for calcinosis, where there is calcium deposits in the skin, the Raynaud's phenomenon, where there is spasm of the blood vessels in response to cold and stress. E is for esophageal dysfunction, where there is acid reflux and decrease in esophageal mobility. S stands for sclerodactyly, where there is thickening and tightening of the skin around the fingers and the hands. And telangiectasis, where there is dilatation of the capillaries causing red marks on the surface of the skin. Scleroderma causes typical increased collagen deposits, which occurs in the periodontal tissues as well as around the commissure and the angle of the mouth. This results in microstomia or decreased mouth opening. The systemic lupus erythematosus is an autoimmune disease with widespread inflammation and tissue damage in the affected organs. Organs affected could be the joints, the skin, the brain, lungs, kidney, and the blood vessels. SLE in the oral cavity presents as lesions which are disc shaped. Moving on, let's look at how pemphigus presents. As we all know, pemphigus is an autoimmune disease wherein antibodies are produced against desmogleins. Desmogleins are proteins that bind the skin cells to one another. Pemphigus is known to particularly affect the superficial layer of the skin or the epidermis and the mucous membranes. This results in blister formation. In the oral cavity, as we can see, pemphigus is causing blisters in the mucosa, buccal mucosa as well as the labial mucosa. Sarcoidosis, like tuberculosis, is a chronic granulomatous disease. Sarcoidosis has a peculiar picture on biopsy of non-caseating granulomas, unlike TB. Sarcoidosis in the oral cavity will cause painless ulcers and brown, red, or purple discoloration of the mucosa, as seen in this picture. Let's move on and look at how Wegener's granulomatosis presents. We know that Wegener's granulomatosis is now termed as granulomatosis with polyangiitis, wherein there is inflammation of the blood vessels in the lungs, the kidneys, the nose, the sinuses, and the ears. Wegener's granulomatosis will cause characteristic strawberry gingivitis or inflammation of the gums in the mandibular as well as the maxillary areas. Now, let us look at some malignant diseases. The non-Hodgkin's lymphoma is a malignant disease affecting the lymphatic cells anywhere in the body, unlike Hodgkin's, which is typically found in the head and the neck. Patients with non-Hodgkin's lymphoma will bring in the classic presentation of ill-fitting dentures or dentures which are not fitting properly. This is because of the palatal masses which is common in non-Hodgkin's lymphoma. Acute leukemias. Monocytic or myelomonocytic leukemias will present with recurrent mucosal ulcerations and bleeding. This is because of leukemic cell infiltration of the gingiva or the gums. So there will be gingival hyperplasia and gingival ulcerations. Multiple myeloma. Multiple myeloma is a plasma cell malignancy in which monoclonal plasma cells proliferate in the bone marrow, resulting in overabundance of monoclonal paraproteins or the M proteins, destruction of the bone, and displacement of other hematopoietic cell lines. The resultant bone erosion causes pathological fractures in the oral cavity. There will be asymmetry of the jaw, and the nerve destruction will cause numbness in the oral cavity, as well as there will be mobility of the teeth because of no bone to hold. Langerhans cell histiocytosis. This is again a malignant disease where there is excess immature Langerhans cells which form tumors called granulomas. They present as bony lesions in the posterior jaw. This bony region will lead to corticular erosion and will give the effect as if the teeth are floating. Now we will look at some nutritional deficiencies. The most common nutritional deficiency is the iron deficiency anemia. Iron deficiency anemia will predispose the patient to aphthous ulcers and angular cheilitis. Angular cheilitis is basically inflammation of the oral commissure and the angle of the mouth. Also, there will be mucosal atrophy and atrophy of the papillae in the tongue. Iron deficiency anemia is very common in patients with Patterson-Kelly-Brown syndrome or also known as Plummer-Wilson syndrome. This syndrome is characterized by the triad of esophageal webs, dysphagia, and iron deficiency anemia. Moving on, let us see how vitamin A deficiency presents. Again, vitamin A deficiency will also cause angular cheilitis or the inflammation around the oral commissure and decreased mouth opening. Vitamin C deficiency is characterized by recurrent bleeding of the gums and petechia formation and ecchymosis. This occurs due to the excessive capillary fragility. Vitamin K is very important for production of critical clotting factors. So vitamin K deficiency will present as recurrent mucosal and gingival bleeding as can be seen over here. Vitamin B12 deficiency, also known as pernicious anemia, occurs because of swelling of the gastric lining or atrophy of the gastric lining. This results because of attack of the intrinsic factor proteins, which subsequently produces vitamin B12 deficiency. So pernicious anemia will present as recurrent aphthous ulcers in the oral cavity, burning sensation, and altered taste sensation, also known as dysgeusia. Vitamin B3 deficiency also presents as cracked fissured lips, atrophic dark tongue, and red patches in the oral cavity. Zinc deficiency particularly presents as dysgeusia or altered taste sensation. Earlier, it was known that patients with recurrent aphthous ulcers should be given zinc supplementation. But recent studies show there is no correlation between zinc deficiency and oral aphthous ulcers. Now, we will be looking at various infectious diseases. Most common infectious disease occurring in the oral cavity would be the fungal candidiasis. Immune dysregulation or immunosuppressive medications predispose patients to Candida albicans infection in the oral cavity. Fungal candidiasis presents in 5 ways. One is the pseudomembranous form. In this, there is keratinocyte desquamation by the fungi, resulting in patches or desquamated patches in the labial mucosa. Second one is the erythematous form, in which we can see there is edentulous ridges of a patient who wears complete dentures or dental stomatitis. In erythematous form, there will be hyperplastic plaques seen in the mucosal surfaces which cannot be scraped off. The third type could be rhomboid glossitis, which is velvety red appearance of the tongue in the especially on the dorsal surface of the tongue and even sometimes in the adjacent hard palate. Candida leukoplakia is a condition which mimics leukoplakia because of the whitish patches produced by the Candida albicans over the tongue. The fifth type of presentation by the fungi could be angular chylitis, which we have already seen previously. Invasive fungi like Aspergillus and Mucor may cause yellowish black lesions over the hard palate and the posterior surface of the tongue. These fungi are invading the blood vessels. So the invasion of the blood vessels by these fungal hyphae can lead to thrombi, infarction, and resultant tissue necrosis. This typically occurs in cancer patients undergoing chemotherapy. Let's move on to some viral infections. The herpes simplex virus is known to cause small vesicles that rupture and then coalesce. HSV1 type of virus typically causes inflammation of the lips or labialis and around the gums as well as the oral commissure known as gingivostomatitis. These are the vesicles of herpes which not only affect the lips but are also affecting the surfaces, innermost lining of the teeth. The herpes zoster virus or the varicella zoster virus also causes vesicular eruptions like the herpes simplex, but the difference is these are along the dermatomes, typically around the fifth nerve distribution and the first division of the fifth nerve distribution. These raised papules with shallow gray or yellow ulcers, they heal, but leaving behind post-herpetic neuralgia. These are the ulcers of herpes zoster virus with reddish discoloration around the ulcers. Let's look at some of the lesions which are strongly associated with the HIV or the human immunodeficiency virus. HIV is known to cause necrotizing ulcerative periodontitis, which is inflammation of the gums, especially around the teeth. Next presentation could be as necrotizing ulcerative gingivitis or inflammation of the gums, diffuse inflammation of the gums. It could also produce gingival erythema, where there is only reddish discoloration around the teeth and pain. Also, HIV may cause hairy leukoplakia over the tongue. This occurs because of the Epstein-Barr virus infection in the HIV patients. Hairy leukoplakia looks like leukoplaque patches in a fungating manner, particularly found over the tongue. The erythematous variant in HIV will look like reddish patches, reddish plaques over the hard palate. The pseudomembranous category will present as keratinocyte desquamation, especially on the dorsal surface of the tongue. Kaposi sarcoma is the tumor of the blood vessels. This presents as reddish brown plaques, especially in the hard palate and the posterior pharynx. Let us look at lesions which are less commonly associated with HIV. The herpes simplex virus causes superadded infection in immunodeficient patients with HIV. These are the typical vesicles which can be seen on the lips in a patient with herpes simplex. The human papilloma virus again can cause blisters with white plaques, especially on the labial mucosa. Condyloma acuminatum produces wart-like lesions in the mucosal surfaces. Verruca vulgaris is characterized by fungating cauliflower-like lesions on the tongue. The herpes zoster or the varicella zoster virus produces reddish plaques and mucosal ulcers in HIV patients. Some other viruses which are known to cause peculiar oral manifestations, one of them being Coxsackie virus. Coxsackie virus is known to cause the hand-foot-mouth disease, which typically affects children less than 10 years of age. It produces blister-like rashes on the hand, foot, and the mouth, along with fever, sore throat, and decreased appetite. Sore throat is because of the painful ulcers which can be seen in the anterior posterior pillars as well as the uvula. Other bacterial infections which have peculiar findings in the oral cavity are the Pseudomonas aeruginosa, Klebsiella pneumoniae, Staph aureus, Streptococcus pyogenes. These bacteria cause typical painful erosions with ulcerations in the pharynx, the tonsils, and they are peculiar in the way they have got whitish fibrinous coverings. Tuberculosis is another bacterial infection which presents as ulcers which are painless, but on biopsy we can see that they have caseous they have got caseous necrosis along with multinucleated giant cells, lymphoid cells, and epithelioid cells. Syphilis is caused by the bacteria Treponema pallidum. The primary syphilis will present as chancre or a painless ulcer, generally over the lip, the tongue, or the tonsils. But secondary syphilis has another presentation. It will present as mucus patches and maculopapular lesions which are coalescing with each other. Now, let us look at some neurological diseases in depth. Parkinson's disease is because the nerve cells in the brain cannot produce enough dopamine. It presents with orofacial pain, oromandibular dystonias, abnormal muscle movements, because of which the patient is predisposed to increased caries and excessive salivation, along with altered taste sensation or dysgeusia. Multiple sclerosis causes damage to the myelin sheath. Myelin sheath is the material that surrounds and protects the nerve cells. This damage slows down or blocks the messages between the brain and the body. This can cause orofacial pain, spasms, and tremors, along with dental caries and inflammation of the gums or gingivitis. Alzheimer's is a condition and is the most common type of dementia. It causes cognitive impairment, because of which patient is unable to take care of his or her oral hygiene. This will cause recurrent dental caries and difficulty in wearing dentures. Stroke. Stroke is caused due to hypoxemia and resulting infarction of the brain cells due to decreased blood supply, the most common being hypertension. Stroke presents as poor oral health, decreased cognitive function, weakness of the facial muscles and tongue coordination, and due to decreased sensory and motor function. Let us deal with some other conditions and how they present orally. The bulimia or anorexia nervosa is a psychological condition in which the patient predisposes himself to a lot of self-inflicted trauma. Recurrent trauma to the oral cavity and pharynx due to recurrent purging will present like this. This is the trauma in the posterior pharynx, and this is the trauma in the buccal mucosa adjacent to the angle of the mouth. This recurrent purging will also cause various nutritional deficiencies, and the patient may also present with dried, cracked lips. Drugs like non-steroidal anti-inflammatory drugs or the angiotensin converting enzyme inhibitors will cause recurrent aphthous ulcer formation in the tongue. Other syndromes like McCune-Albright syndrome, Peutz-Jeghers syndrome, and neurofibromatosis type 1 can cause increased mucosal pigmentation in the oral cavity. Now I want to discuss the precancerous lesions, the difference between precancerous lesions and precancerous conditions. So a precancerous lesion is basically a morphologically altered tissue in which the oral cancer is more likely to occur than its normal counterpart. Three main precancerous lesions I would like to discuss today are the leukoplakia, erythroplakia, and palatal lesions in reverse smokers. Precancerous condition is a generalized state associated with significantly increased risk of cancer. The conditions we are going to discuss today would be submucous fibrosis, actinic keratosis, lichen planus, and discoid lupus erythematosus. What is leukoplakia? Leukoplakia is the term which was first used by Schwimmer in 1877. He used it to describe a white lesion of the tongue. Leukoplakia is the most common pre-malignant lesion, constituting 85% of the cases. WHO has defined leukoplakia as a whitish plaque that cannot be characterized clinically or pathologically as any other disease. How to diagnose a leukoplakia? Any whitish patch, if we rule out is not any other disease, which we have discussed today, we will provisionally diagnose it as leukoplakia. We will post the patient for a biopsy, and the biopsy will reveal a leukoplakia with dysplasia or without dysplasia. Let's look at the modified staging of leukoplakia. In phase 1, we can see that there are thin gray white translucent plaques which are still soft and flat. The phase 2, the leukoplakic patches will be still homogeneous, but now they will be thickened or fissured. The phase 3, where we can see that the surface of the leukoplakia will appear to be nodular or granular or a verruciform surface. In the phase 4, we can see erythroplakia or reddish discoloration and speckled leukoplakia or non-homogeneous type of leukoplakia. So the clinical presentation of leukoplakia would be like this. This is the homogeneous leukoplakia where uniform white patches can be seen. It has a lower pre-malignant potential definitely. The non-homogeneous variety of leukoplakia, where there is speckled or verrucous leukoplakia, has a higher malignant potential. Leukoplakia is found 70% of the cases will appear in the buccal mucosa and in the commissural regions. It can be followed by the lower lip, floor of mouth, tongue, palate, and the gingiva. Erythroplakia. WHO defines erythroplakia as a lesion of the oral mucosa that presents as bright red velvety plaques, which cannot be characterized clinically or pathologically as any other recognizable condition. Let's look at the classification of erythroplakia. It presents in three variants. One is homogeneous erythroplakia. Second will be erythroplakia, which is interspersed with patches of leukoplakia or whitish plaques. And the third will be the granular or the speckled erythroplakia, embracing the lesion described as speckled leukoplakia. Erythroplakia definitely has more malignant potential as compared to leukoplakia. Clinically, it will look like smooth, granular or nodular and well defined, or it can be irregular with red granular surface It can be interspersed with whitish patches or leukoplakia. It is generally soft on palpation. Now let us look at the pre-malignant condition called oral submucous fibrosis. Oral submucous fibrosis, or OSMF, is insidious in onset, and it can affect any part of the oral cavity, sometimes the pharynx. Although occasionally preceded by vesicle formation, mainly it is characterized by juxtaepithelial inflammation and subsequent fibrosis of the lamina propria layer of the epithelium. This causes subsequent stiffness in the oral mucosa, resulting in trismus or difficulty in opening of the mouth and inability to eat. Let's look at the clinical staging of oral submucous fibrosis. In stage 1, it will generally present with difficulty in mouth opening or stomatitis because of erythematous vesicles, ulcers in the mouth, increased pigmentation, and petechia formation. In the second stage, we can see inflammation is preceded with fibrosis because the ulcers will heal, the vesicles will rupture. This is generally the hallmark of the stage. In the third stage, we can see some sequelae of oral submucous fibrosis. Sequelae could be in the form of superadded leukoplakia, which occurs in 25% of the individuals, and subsequent speech and hearing deficits because of involvement of the tongue and the eustachian tubes. As we can see in the picture, excessive fibrosis and stomatitis will result in restricted mouth opening, also called trismus. Let's look at the functional staging. In group 1, we can see these symptoms: vesicles, ulcers, burning sensation in the mouth, altered taste, but no restricted mouth opening. In the group 2, we can see the mouth opening is still more than 2 centimeter. In the group 3, we can see mouth opening is less than 2 centimeter. And the group 4, we can see limited mouth opening and definitely a higher chance for cancer. Let's look at another pre-malignant condition called oral lichen planus. Lichen planus was named by E. Wilson, who was a British physician in 1869. Lichen in Latin stands for primitive plants, like fungi, and planus means flat. Lichen planus has a typical white, lacy, flat appearance, generally in the buccal mucosa. It is defined as a common chronic immunologic inflammatory disorder that varies from a keratotic to erythematous and ulcerative, affecting the stratified squamous epithelium. The clinical features include lesions which are usually symmetrical, frequently affects the buccal mucosa, the tongue, gingiva, lip, and the palate. There are extraoral mucosal involvements. There could be genital region, conjunctiva, esophagus, or the larynx. Approximately 1.2 to 5.3% lesions undergo malignant changes. Therefore, patients with lichen planus have to be asked to follow up regularly. Let's look at some other pre-malignant conditions. Nicotine stomatitis is where it usually occurs in smokers. The palatal mucosa becomes thickened, hyperkeratotic, and sometimes developing even fissures. Reverse smoker's palate occurs in patients who are smoking the cigarettes in the reverse direction. This causes more heat-related damage to the palate and alteration of the palatal mucosa, which increases the risk for malignancy, as can be seen in this picture. Actinic keratitis is commonly occurring on the sun-exposed surfaces, especially on the lips. And there is hyperkeratotic plaques, which can be seen over the lips due to alteration of the epithelium. This picture depicts How clinically and histologically a normal mucosa with an intact basement membrane would look like. So this is the normal tongue. This is the tongue with a precancerous condition or leukoplakia. Leukoplakia is a pre-malignant lesion, so the basement membrane is not eroded, but definitely there is increase in the cell count or dysplasia. And this could subsequently progress to tumor formation due to genetics or increased nicotine intake, where the basement membrane gets eroded and there is hyperplasia. I would like to discuss this case where a 63-year-old person with such a lesion on the tongue presents. This is a case for discussion. It is open to discussion. So basically, there was no improvement even with the topical corticosteroid or even a systemic corticosteroid like prednisolone. So such a non-healing ulcer, what DDs would you come up to? Patient also has angina and diabetes and is dependent on diabetes. Sorry, he has got insulin dependent diabetes. I have got some answers. Candida infection, precancerous lesions. Okay, but it typically looks like an aphthous ulcer. No, I want the most common cause. What is the first most common cause coming to your mind? Because it is in the lateral border of the tongue. Okay, it could be vitamin B12 deficiency, definitely. But it is in the lateral border of the tongue. Yes, it is an aphthous ulcer. Okay, but why is this ulcer there? Yes, it is because of some abnormality in the tooth. So first thing you will suspect is trauma due to teeth. Yes, yes. But okay, so now we'll look at the next slide, which shows the answers. So it is an aphthous ulcer, but our main DD would be that it is due to dental trauma or some chemical burn, or it could be due to hot food. But if it is not healing with the application of prednisolone as well as systemic or topical, then definitely you will go in for a biopsy to rule out squamous cell carcinoma. Now I am open to questions. If anybody has any questions. Please message in the chat box and we can discuss them in detail. How to differentiate oral submucous fibrosis from leukoplakia and candidiasis? Okay, so since I told you that this entire presentation was about how you will correlate the oral manifestations with the systemic diseases. So you have to have an overall look at the patient, deal in depth whether they have got diabetes, hypertension, all the systemic conditions. You have to correlate them with the oral presentations. Directly, you will not be able to come to the conclusion that it is oral submucous fibrosis, leukoplakia, or candidiasis. But if the patient's condition is immunocompromised, he has got long-term non-healing ulcers because of high blood sugar levels, then you can come more close to the that he will have candidiasis more than leukoplakia. But if the patient is not having any systemic condition of diabetes, hypertension, but is having some genetic history of cancers or family history or excessive use of nicotine, then we will suspect leukoplakia and cancer in that patient. So the difference between how to differentiate between different oral lesions is purely clinical. You have to look at all other factors also, not just the oral cavity. It will be a holistic approach that you have to take. I have one more question. Patient. Okay, patient is coming with bleeding angle of the mouth, mucositis over the bilateral buccal mucosa with pain and bleeding. Okay, in this case, since there is a lot of bleeding in your question, we will first suspect if there are any platelet disorders. So you will do a complete blood count, you will see the platelet levels, and then your diagnosis should you should go towards nutritional deficiencies in this case, because there's a lot of bleeding involved. Liver diseases also should be ruled out, whether the patient is alcoholic. So when we used to take history for patients coming with pre-malignant lesions or malignant diseases, in the history, addictions are very important, and addictions have to be discussed in depth. How many cigarettes, how many packs of cigarettes in the day, and for how many days, and for how many months and years. Entire history is very important. Again, alcohol, how much quantity of alcohol, how many times in a day, for how many days, over how many years the patient is addicted. Addictions are to be discussed in detail. Leukoplakia, when to get it investigated. Okay, if a patient comes with a whitish plaque over the tongue or the buccal mucosa, labial mucosa, anywhere in the mouth, if there is a whitish plaque, uh, give topical corticosteroids. If it is not healing, or local application of topical lignocaine, give him vitamin B12 medicines. If it is still not healing over a month, definitely post the patient for a biopsy, because even leukoplakia could present with dysplasia or without dysplasia. You definitely want to follow up a patient having leukoplakia with dysplasia, because that has more malignant potential. Okay, in angular cheilitis, how long we have to give supplements? Angular cheilitis, why it is occurring is important. That will change the protocol and line of management. And it's better to give supplements, especially vitamin supplements, in the form of injections. First, give it in the form of injections and then convert it to the oral supplements and give them over a period of 6 months or 1 year, because vitamin deficiencies don't cure overnight. Also, refer the patient to a dietitian. He has to change the diet. There is some dietary problem which is causing the vitamin deficiency. Yeah, the bleeding, again discussing that question where someone is asking, patient presenting with bleeding over the angle of mouth, lips, mucositis. Yes, it could be, I told you, it could be some platelet disorders, or